TP recap is basically when three wonderful members choose a case each from the month before that really stood out to them and share what they learned and teach us more about it. So today we have Glenn, Mohammed, and myself. And yeah, we'll start with Glenn and then I'll go. So Glenn, are you ready? Do you want to start sharing your screen?
Thank you, Masa. I'll be going first. So those who don't know me, Glenn, I'm a medical student in Botswana. So uh, doing teaching points recap today. So let me share my screen. Uh, can you all see my screen?
Yeah,
Yes.
always good.
Okay. So I'll be teaching on a case that is on the 19th. A neuro VMR presented by Fahad and Dr. Shi and Vali. We're the one discussing. So just to get to the problem representation, so chief complaint was a 63-year-old male presented with 9 months of dream enactment. So to go over the components of the HPI that were relevant. So patient had excessive daytime sleepiness associated with delusions and hallucinations. There are some associated urinary incontinence happening at night and some weight loss, which is approximately 10 kg unintended. So from here, we're gonna try to generate differential diagnosis from the presented symptoms. So from the sleep disorder, autonomic symptoms, and motor symptoms, anyone in the chat can just type what any like one condition that would think can cause this constellation of symptoms. So like I tried to divide the causes into like three main buckets, but they could add more. So we can have primary sleep disorder, one of those being REM sleep behavior disorder. So this one will present with dream enactment that you saw in the case, and also you can have severe obstructive sleep apnea. Uh, Another bucket to consider. Uh, can you still see my slides?
Yes.
For some reason, I can't move my slides. I don't know what's happening now.
Do you want to refresh?
All right, I managed. Okay, so yeah, so the second bucket of differentials would be the neurodegenerative disorders. You can think of dementia with Lewy bodies because of the hallucinations and delusions that I mentioned. You can also think of Parkinson's disease, which has some motor symptoms as well. Another thing is the autoimmune inflammatory bucket. So autoimmune encephalitis can cause this as well, and paraneoplastic syndromes. I mean. So we're gonna continue the rest of the findings in the exam and the investigation. So for the neurological exam, there are some hypometric saccades and broken pursuit, axial dystonia, mild tremor, there's some myoclonus, diffuse fasciculations, lateral muscle wasting, and the gait was swinging to the right. So from all of these findings, we can just summarize them into like lower motor neuron signs, brainstem signs, extrapyramidal signs. Just to continue on the labs and the imaging. So the metabolic panel was normal. The SF protein was mildly elevated. For the imaging, pertinent thing was the The MRIC spine shows some mild degenerative changes. EEG showed generalized dysrhythmia, and neuro conduction studies showed bilateral sensorimotor neuropathy, and EMG showed fasciculation. So from here, I would ask a question to all of you. So whether this thing will be a central process, peripheral process, or both. Looking at the investigation in the slide, just EMG, neuroconductive studies, and imaging. So I would agree that this is both a central and peripheral process based on the fact that these EEG findings and the fasciculations on the EMG. So just to summarize on just the case summary itself. So patient had sleep disorder, brainstem signs, movement disorder, and neuropathy. So from here, you wanna do further test, autoimmune and paraneoplastic workup. And there anyone who would think of a differential from these two, autoimmune and paraneoplastic, that would fit best into this case, provided the sleep disorder brings some signs and neuropathy. Okay, so I'll continue with the findings of the autoimmune and paraneoplastic workup. And the next, so the CT abdo and thorax was negative, the serum paraneoplastic panel was negative, autoimmune encephalitis panel was pertinent for IG1105. So the diagnosis was anti-IgA1105 disease. So what is anti-IgA1105 disease? This is one of the rare autoimmune neurologic disorders. So what happens is that the antibodies are produced against IgA1105, which is actually a molecule, neural adhesion molecule, and there is some strong HLA association with some GRB1 association. So according to the pathophysiology, you can think of it into two. There's the autoimmune component and the neurodegenerative component, with the autoimmune component being neuronal dysfunction from the that neural adhesion molecule that has been attacked by the IgG4 antibodies. And then there's tau deposition, which is the neurodegenerative component. And one thing to note is that it mostly happens in the brainstem and the hypothalamus involvement. So this will explain the findings that we talked about sleep disorders. So for sleep symptoms like sleep enactment, they will come because in the hypothalamus, that's where your sleep physiology occurs. So this the suprachiasmatic nuclei in the anterior hypothalamus, that's what generates the sleep physiology. This also in the brainstem, there is some physiology in there. That's what creates the symptoms of sleep enactment. And also another symptoms that we can have, there is bulbar dysfunction as well, striatum. This is all because of the brainstem involvement, because most of the cranial nerves are in the brainstem. There's also gait and movement disorders. So how do you manage this condition after diagnosing it? So mainly through immunotherapy, since it's an autoimmune condition, so you can give steroids, IVIG, as well as plasma exchange. Can do symptomatic ones because of the brainstem involvement, they're at risk of airway problems. So airway protection is one of the measures with CPAP as well. Then another interesting drug that's given is levodopa. This one is given because these patients also tend to have Parkinsonism features, symptoms. So it can help with the symptoms, but it won't reverse the condition. You just give a partial response to the condition. And let's just go through the prognosis. It's a chronic and progressive condition. There is most commonly a delay in the diagnosis, like in this case. You then you start um, just trying to diagnose sleep disorders, and you do the autoimmune workup late. That's why there's a delay in in the diagnosis, and the response to immunotherapy is variable. Um, there's also risk of uh, death, mostly because of the brainstem involvement and the striders that you can get. So just to close off my teaching, so this case really suggests that sleep disorders, if it's atypical, could be a feature of a serious neurological disease. So you need to investigate more to so that you don't miss out diseases like IgLN5 disease. Thank you, everyone. These are my references.
Thank you very much, Glenn. Thank you for teaching us about that. This is definitely very enlightening. I have heard of anti-IgLN5 disease before, so thank you very much. So I'm gonna go next, and then we'll hear from Muhammad. So let me share my screen. Oh, can you guys see my screen?
Yeah, we can see it.
Okay. So, hey everyone, I'm Masa, and I will be recapping the case that was presented by our lovely Shreya on the 8th of January. And I actually discussed this case with Robbie, so I thought this would be great learning. So, this was a case of an 80-year-old female who presented with abdominal pain for 3 months and bilateral leg swelling for 20 days. And she had a past medical history of non-ST elevation MI with HFrEF, AFib, hypertension, and a gastric ulcer. And she was on amiodarone, losartan, apixaban, and metoprolol with no other significant family or social history. On examination, she had elevated heart rate and blood pressure and bilateral leg edema up to the knee. Her labs showed AST and ALT elevation with otherwise normal synthetic liver functions, and her EGD showed varices, and ultrasound showed portal hypertension. She had a high SAG. And so she was ultimately diagnosed with decompensated liver disease. However, Robbie was alluding to a non-cirrhotic portal hypertension. So let's talk about that. But before we go into that, let us refresh our memory on some anatomy. So if we remember the blood supply of the liver, it has a dual blood supply. So it gets 20% of its blood supply from the hepatic artery, which carries oxygenated blood, and it gets 80% from the portal vein, which will carry nutrient-rich deoxygenated blood. And these two will eventually mix at the sinusoids and then nourish the hepatocytes and then drain into the hepatic vein, into the IVC, and back to the heart. So before we talk about the portal venous system, let's talk about what normally happens in a venous system. So usually what happens is that the heart will pump out oxygenated, nutrient-rich blood into the arteries, and then it goes to the arterioles and then the capillary beds, which is this network of capillaries where exchange takes place. And then it would drain the oxygenated blood into the venules, the veins, and back into the heart. So this is what normally happens. Whereas in the portovenous system, And as you can see, I'm literally an artist. So please rate my drawing. Anyway, so what happens is it goes from capillary bed to capillary bed and back to the heart. So basically, um, the the veins from the pancreas, from the spleen, from the anal canal, all drain into the portal vein, into the liver, and then, as we mentioned, it mixes with hepatic artery and then drains into the hepatic vein and into the IVC and back to the heart. And so that's what makes the portovenous system special. So, what is portal hypertension? It is increased pressure in the portal venous system, and this is driven by increased resistance. And the gold standard to measure that would be the hepatic venous pressure gradient, which uses a catheter to essentially measure the pressure gradient between the portal vein and the IVC. And more than 5 millimeter mercury is elevated, with more than 10 making it clinically significant. But a simpler way to check for portal hypertension would be getting an EGD and looking for varices, because most of the time, varices are due to portal hypertension, with the rare exception of splenic thrombosis. So, what are the different sites that can cause portal hypertension? We have prehepatic, which is outside the liver and includes splenic vein thrombosis, portal vein thrombosis, or extrinsic compression of the splenic or portal vein. And then we have intrahepatic, which could be pre-sinusoidal, which is basically the portal vein that at a microscopic level before it gets to the sinusoids. And that includes schistosomiasis, sarcoidosis, and so on. We have sinusoidal intrahepatic, including cirrhosis and some infiltrative diseases. And we have intrahepatic post-sinusoidal, including sinusoidal obstruction syndrome. And then we have post-hepatic, which includes congestive hepatopathies like congestive heart failure and constrictive pericarditis, or a hepatic vein thrombosis. But 90% of the causes of cirrhosis, of portal hypertension, are cirrhosis. And so it might be easier to clinically identify whether this is a cirrhotic portal hypertension or a non-cirrhotic portal hypertension. So in cirrhotic hypertension, portal hypertension, the sinusoids are involved. And when the sinusoids are involved, these sinusoids are very leaky vessels. And so that is basically what causes ascites. When there's a lot of pressure in these leaky vessels, they start to leak out all this fluid and cause ascites. We also have impaired hepatic function because of damage to the hepatocytes, and hepatic encephalopathy because of hyperammonemia, and ammonia will bypass the liver. And we can take a look at the neutrophil to lymphocyte ratio to predict the severity of cirrhosis. And in non-cirrhotic portal hypertension, we will have a preserved hepatic function because the hepatocytes are spared. And there is a common ground of thrombocytopenia in cirrhotic hypertension. The thrombocytopenia is because of decreased thrombopoietin production, whereas in non-cirrhotic portal hypertension is because of hypersplenism. So now that we've identified whether it's cirrhotic or non-cirrhotic, well, in our case, we can take a look and see that here we had thrombocytopenia. We had a preserved synthetic liver function. We have normal PT, PTT, and INR. And we have minimal ascites or moderate ascites. And in this case, with the preserved liver functions, preserved ALP and total bilirubin, although albumin is low, it is not a great predictor of synthetic function of the liver because It has a short half-life. It's a negative inflammatory marker, and it's sensitive to change. So PT, PTT, and INR is more reliable to look at. And so in this case, we were leaning more towards non-cirrhotic portal hypertension. And now we can divide it further based on the location. And to do that, again, we can talk about whether it involves the sinusoids or not. And if it involves the sinusoids, then it will most likely have ascites. If it doesn't involve the sinusoids, then what happens is that this fluid will back up into the other vessels, which are larger and they're thicker walled and they don't leak easily. And so this pressure starts getting shunted through collaterals. And in this case, we'll have more varices and more splenomegaly. And to differentiate, let's say, between a prehepatic and an intrahepatic pre-sinusoidal, we basically have to ask ourselves if this is macroscopic or microscopic. So if you could see it on imaging, whether an ultrasound or a CT or a CTPA, then it then we can say that this is prehepatic. Whereas if we cannot see it, then we would need a biopsy to identify the pre-sinusoidal cause. And the same thing with sinusoidal, post-sinusoidal, and post-hepatic, where it could be macroscopic and post-hepatic using an echo or an ultrasound to identify any of these causes. Otherwise, a biopsy would be needed to look at the more microscopic causes. And so, as we mentioned, a pre-sinusoidal or prehepatic would have more collaterals, minimal to no ascites, prominent varices, ectopic varices, and massive hepatomegaly because this fluid is not leaking and it's all just backing up. And with hepatic or post-hepatic, we have hepatomegaly because the liver is involved, ascites, some mild splenomegaly, and hepatic encephalopathy, mostly in sinusoidal, as we mentioned, because of the damage to hepatocyte and hyperammonemia will bypass the liver. But we can also have hyperammonemia in the pre-sinusoidal prehepatic portal hypertension in later stages because of major portosystemic shunting. And that is all. And so once we've identified that this is a non-cirrhotic portal hypertension, we can also divide it into a couple of buckets in order to find the cause. And I got the schema from Kirtan, so thank you, Kirtan, for that. So we have autoimmune conditions that can cause non-cirrhotic portal hypertension. We have some infectious causes like schistosomiasis or HIV. We have metabolic causes, infiltrative causes, certain drugs and toxins. And in our case, our patient was on amiodarone. So this is most likely the reason that she was experiencing these symptoms. We have some hematologic causes, genetic causes, and finally, neoplastic and radiation. And that is all for today. Thank you very much for listening. And these are my references. So I'm going to stop sharing my screen. Thank you guys for listening. And Muhammad, please go ahead and share your screen and start your presentation.
Hello, everyone. Can you hear me? Let me just...
Yes, we can hear you.
Let me just adjust the stop sharing. So hello, everyone. My name is Muhammad. I am a medical graduate from Iraq, and I have a case that is similar to MASA. It's also hepatobiliary and GI. So this case is from January 14th, 2026, presented by Dr. Raji Jovalan and case discussant well, Dr. Elliot Tapper, and also Dr. Kuchal. So let's get started. So this patient is a 20-year-old female with a previous history of depression and suicidal ideation, presented with elevated liver enzymes and tonic-clonic seizures and hypoxia. So let's move on and split as the teaching points. We split these data points into the age of the patient, past medical history, and also the presenting symptoms. So from the elevated liver enzymes and depression and suicidal ideation, we should think about toxin ingestion in this patient, including acetaminophen. From the elevated liver enzymes and seizures, we have to determine the relationship between the elevated liver enzymes and seizures. Which causes the other? Which influences the other? For example, in a liver injury, hyponatremia could cause seizure. And also, in patient with seizure, could have a problem of increased ammonia. So, for example, patient with seizure could cause, as a consequence of seizure, convulsions and rhabdomyolysis, causing hyperammonia, mimicking liver injury. And also patient taking anti-epileptic medicines could have increased ammonia, mimicking liver injury. So this patient with this complaint have vitals, tachycardia, she's hypoxic and has BMI of 40. On exam, she was intubated and sedated and admitted to the ICU. So here we have to send the patient for laboratory. So we have the white BC3K, hemoglobin is 8.1, creatinine is elevated, her baseline is 0.5, now it's 4.6. There is acidosis and is very high LDH. Also, we can see very high AST of presenting as 4,000 and 6,000, ALT of 800 and 900, and also we have elevated alkaline phosphatase. We can see also the INR is normal. So getting from MASA session, INR is normal. It's not elevated, and bilirubin is not elevated. At this point, I want to ask, what do you think the causes of very high liver enzymes above 1,000? You can write in the chat.
Well, thank you.
So we have a very good schema from the CPS website elaborating on this subject. We can see at the right top of this image that the top causes of very high AST and ALT, it is the ischemic hepatitis, followed by choledocholithiasis, then drugs, including antibiotics, anti-tubercular, and also anti-epileptics, and also viral hepatitis, including hepatitis A and hepatitis E. So this is a very good diagram that shows, and also getting from MASA session about the sources of ischemia. The ischemic hepatitis is not like ischemia from the arterial side. It could be from the venous side. For example, right heart failure and Budd-Chiari syndrome could interfere with the sinusoidal perfusion and causing ischemic hepatitis. So this patient now have extended workup as any patient with acute liver injury. So toxicology is negative. Virology, including A, B, C, EBV, and CMV are negative. Autoimmune workup is negative. Seroplasmin, ferritin is negative. Liver ultrasound was negative. CT abdomen pelvis was negative, and MRI brain was negative. So what left for this patient? So this patient course, she was intubated in the ICU and started on CRRT because of her acidosis, started on non-acetylcysteine because of suspicion of toxic injury. 2 days later in the ICU, the patient had upper GI bleeding and melena. So this upper GI bleeding and melena, the EGD was arranged for this patient, and we found multiple punched out gastric and esophageal ulcers. So at this point, this is we can see on the left side are the gastric ulcers, and on the right side, we have the esophageal ulcers. I have a question, another question. What are the causes of multiple ulcerations in the context of this patient symptoms? So this patient who is sick and in the ICU, as in many patients with sepsis or any patient with hypertension, are very risk of injury to the mucosa. So ischemic mucosa causing ulceration and bleeding. And also the patient also, the multiple ulcerations raise concern for infectious etiology, for example, HSV and also cytomegalovirus. You know that HSV and cytomegalovirus are not standard when checking in patients coming with acute liver injury. So we extended viral panel sending for CMV and HSV. CMV was negative. HSV IgG was negative, but HSV PCR was very high for this patient. So this patient, the final diagnosis, collecting this patient's symptoms, CNS, seizures, high liver enzymes, GI ulcerations, GI bleeding, was diagnosed with disseminated HSV, including hepatitis, esophagitis, and encephalopathy. This patient, HSV, it's common in the immune-compromised population. So this patient was screened for any immunodeficiency. There is very rare immunodeficiency was found in this patient. It's called SAM-HD deficiency. It's make the person susceptible for viral infections. Here I want to tell you a bit about HSV. HSV is rare, life-threatening cause of acute liver failure and ulcerations. And the triad is very high liver enzymes, and also ulcerations. Diagnosis is a PCR. As we see in this case, IgG were negative. So PCR is the gold standard for diagnosis. In some case reports, it was reported that high LDH, as in this case, and although the very high AST, but AST to LDH ratio less than 1, it's correlated with HSV infection. So this patient was started on acyclovir. Unfortunately, her liver enzymes and ventilator settings were down and was extubated. So take-home points from this case: young patient, elevated liver enzymes, her history of depression and suicidal ideation. We have to prioritize toxin injury, especially acetaminophen. Elevated liver enzymes, very high, more than 1,000. We have to consider this narrow differential: ischemic injury, cholelocholitiasis, drug-induced liver injury, and viral hepatitis. In a patient with very high AST, very high ALT, AST to ALT ratio is not that important in identifying the etiology. No matter how AST to ALT ratio like 2 to 1, we cannot say, for example, it is alcoholic liver injury. In this patient with query a course, we sent for everything, but we should consider context-based testing. For example, ferritin, in this case, cannot tell us the patient have hemochromatosis because ferritin is acute phase reactant and could be high. And ceruloplasmin, there's many studies shows that advise against testing seroplasmin and hemochromatosis in acute setting like that. So we have to focus on the patient acute resuscitation. And at the end, HSV is rare, but we should consider it in immune-compromised states and also in pregnancy. And these are my references. Thank you very much for listening.
Thank you so much, Muhammad, for this wonderful presentation. You speak very eloquently. So thank you everyone for joining. If you have any questions, let us know. Yeah, I hope you guys learned something today. Yeah, really appreciate everyone being here. Thank you very much. Have a lovely, lovely evening.